Thank you so much for this opportunity. It's always great to speak with everyone at CAIRIBU. I get so much out of this collaboration. And I recognize many people on the Zoom, so please feel free to interrupt me, ask questions. I'd like this to be as much of a conversation as possible. I don't have any commercial disclosures. As you said, I am on the UroEpi grant, and I am focusing this presentation on the work that I've been doing under this award with my mentors, Dr. Clemens and Dr. Sarma here at the university. So a brief outline, I'm going to go over what I've been doing on the K12 and then also talk about my next steps. I am planning to put in an R01 based on this K12 in June, which is coming up very quickly. So I'm very open to getting feedback on those ideas I have. So this diagram sort of summarizes why I'm doing this work. Overactive bladder, as I think everyone in this group knows, is a chronic syndrome characterized by urinary urgency, frequency, and urinary incontinence. And it is the treatment for overactive bladder has traditionally been the stepwise process that starts with behavioral intervention, that goes to medications, and then traditionally has gone to what we call third-line therapies. And while that seems pretty straightforward from a clinician standpoint, on the patient standpoint, they're often faced with, or they are faced with, a roadmap that looks like this, which to me as a clinician even seems very confusing and daunting. And so my goal has been to leverage shared decision-making and health services research to try and make decision-making and management of overactive bladder more patient-centered. And this has been done through identifying, quantifying, and decreasing the barriers to diagnosis and treatment of OAB, and also to by improving patient and clinician education and decision-making. So for this K12, it's a mixed methods research project. The first aim was qualitative. So this was interviews with patients and clinicians that we have transcribed and coded, and I will present that work. And that sort of parallel with that work, we are doing quantitative work, which pulled from a database through our EMR, electronic medical record, which has over 300,000 people with a diagnosis of overactive bladder, and used health services research methods to try and create what's called a computational phenotype to correctly identify people with overactive bladder syndrome, and also then track their outcomes over time. And this all is preparing for future work that is hopefully aimed at identify who gets access to those third-line therapies, what characteristics they have, what is the impact of payers or insurance status on getting that access, and then sort of challenging the current paradigm to see, are there methods away from the step-line therapy or step-up therapy that we currently use to do something more patient-centered, maybe that would bring those advanced therapies up sooner and be more accessible and available to people that they might benefit most. Okay, so for the qualitative project, this was what we call exploratory sequential. So we created an interview guide, did interviews, and then used that to inform our health services research methods. So after the interviews and the surveys, we coded and transcribed, and then we came up with themes. I've already presented this work to this group, so I'm sort of running through this a little bit quicker to try and get to some of the newer findings that we've had. So basically this was parallel. So there were physicians and clinicians. So we generated themes from both groups, and then we integrated them to themes that were that translated amongst both groups. And what we found were a few main themes. First, both from clinician and patients, there's like this overwhelming frustration with the inaccessibility of OAB treatments. Patients having to pay copays to access things that we think are first-line therapies that can be pretty pricey. physicians saying they can't start the therapies that they think would benefit the patients most because of insurance barriers. There is a really huge discordance of the perception of patient education. So patients feel that they are not receiving education that's appropriate. They don't understand the pathway and the options that are available to them. Whereas physicians across the board said they spent a lot of time educating patients and providing them like resources to learn about overactive bladder. One of the really interesting points is that there's a divergence of acceptability of expected outcomes. So what this means is that on the physician side, we as clinicians feel like a 50% improvement in symptoms is a clinically significant improvement, and that is sort of our goal. Whereas on the patients, we had quotes like this one that said, you know, just 50% better doesn't seem good enough to me. And so this divergence of expected outcomes means there's a huge gap in what, you know, clinicians and patients think is acceptable, which leads to people being really frustrated with the outcomes of their treatments. And then I think the final theme that we found that was sort of ubiquitous was that there's this really lack of insight and lack of transparency of what the other parties' decisional priorities are. And this played out in the way that different people prioritize different things. So patients, we found, prioritized efficacy. So they wanted the treatment that was going to get their symptoms resolved the quickest. And they were willing to maybe compromise or leverage some safety or take on risk to accomplish that goal. Whereas clinicians seem to really prioritize avoiding risk and safety and because there was a lack of transparency, then there were quotes like the one that I have where I use that to steer patients one way or another, which is very, you know, paternalistic and doesn't really align with shared decision-making. So based on this, I created a few actionable items that are going to inform future work. I think the biggest next step to me is to start systematically trying to quantify and decrease barriers to OAB treatment to address that first frustration that's both apparent for clinicians and patients, that they can't access the therapies that they want. And often the barrier is step therapy, limitations like requiring certain meds before you can access other meds, or requiring meds before you can do advanced therapies. Promoting what I call transparency in decisional priorities and decisional control preferences. So we don't have to be aligned in priorities, but we need to be transparent with our patients. So this has changed how I counsel people. I now say things like, what's important to me is that you don't have a complication. And this is why I think this choice might be better, but it sounds like what's important to you is to get, you know, the therapy that might get you your symptoms cured the most. And so then we have a conversation about pros and cons so that it's not this sort of people pushing their own agenda, or not really people, but clinicians pushing their own agenda and not listening to their patients. To address the lack of education, I think OAB, especially the pathway that we have traditionally recommended as clinician, is this what we call a roadmap. And when you think of a roadmap, it has a beginning and an end, which for a chronic syndrome like OAB, I think is very confusing both for clinicians and providers, because it doesn't mean just because you go through all the steps, it doesn't mean that this condition is going to go away. And so I think we are really doing a disservice to ourselves as clinicians and especially to our patients by pushing sort of a linear roadmap for this condition. And really, it should be more like a menu or a sort of a this is a toolbox of what we can do to make you feel better and improve your quality of life. And then really trying to finally give data that's patient-specific on what they can expect for their treatment outcomes, and making sure patients understand, like, what they can expect from a medication or a treatment, and whether that expected outcome is suitable for them to undergo what we as clinicians may offer. The next steps go into these, like, quantifying and decreasing the barriers. So one of the barriers that we found in this work, and I wasn't expecting to find, but I think has really changed my agenda a little bit, is that without being asked about stigma and shame, these interviews really brought up a lot of the social impact and personal emotional impact of having overactive bladder, that I think, even despite talking to hundreds of people with this condition in the office, I never really understood until I performed this work. And so one of the next steps for me in decreasing barriers is try to really understand the impact of the emotional and psychological toll that OAB does on how people choose to seek care, or how that impacts their decisions to undergo certain therapy. So this is a paper that's under review, and it's basically a whole different set of themes that came out organically in the middle of conversations about decision-making for overactive bladder care. And what we found is that OAB is incredibly isolating, and people, there's this not only lack of education, but also lack of feeling like there's an OAB community. I know a lot at SUFU, we often talk about there's no poster child or champion for overactive bladder. So people don't feel like they can talk about this with anybody, even in their own peer group. And they feel like they have never been counseled on this as a possible condition as they age, especially around menopause. There is a lot of stigma associated with noticeable OAB symptoms, and people with overactive bladder spend a lot of their time trying to mask those symptoms. There are people that told stories about how they sort of manage their incontinence products because they have so many pads, and they like hide when they're taking out their trash. They can't travel or if they are traveling, they think of a strategy of how are they going to throw away all their pads when they're staying at a friend's house, so their friend might not know how many products they're going through. People don't speak to their spouses about this. And a lot of people brought up this feeling like they're like a school-age child, and there's a lot of like social stigma around incontinence. We as providers are a source of embarrassment and for patients, and a lot of the workup of overactive bladder is incredibly invasive, and people might not really. I've tried to be better about explaining what a urodynamic study or a catheter or being catheterized might what that process is like, but it's still a pretty invasive workup for this condition, and it is really hard for patients to even open up when we're asking about directly about their symptoms, even they're seeking care. And so I've tried to, as much as possible, make a safe environment for people to share their condition, but I think we have a lot to do in that regards. And sort of to go on more about that, I think because there is a paucity of people that treat incontinence and education about incontinence care and overactive bladder care in medicine in general, that people feel really dismissed, and they're not a lot of people come to me and say, well, I've seen 3 other doctors who've said this is just a normal part of aging and there's nothing to do about it. I really hate the second quote, that even clinicians feel like these patients are quote unquote throwaway patients, which is like a terrible quote that we had from a clinician. And so that gets into that there's clinicians who care for this syndrome feel like their work is undervalued, and the patients they're taking care of are less valued than compared to other clinicians, which is sort of a different perspective to think about. And finally, I think OAB patients are a vulnerable population, and they have this sense of desperation for a cure, which makes it, which I think clinicians should be really mindful of, because of the possibility to exploit those vulnerabilities, and especially in a shared decision-making or in a decision-making dynamic. So the first quote, people, even though they're well-educated, they just they get to a point of desperation and they'll try anything if they think that it'll help them be able to get over this. And that is something to really think about when we are counseling people on their clinical decisions. So for me, these themes were impossible to ignore. They really weren't what I set out to find, but they have really informed how I view OAB as a syndrome and the impacts of it, but also sort of added another layer of nuance to the dynamic between clinicians and patients that I'm hoping to understand more, but also inform other clinicians about, so that they're more mindful of these things that they might not be asking about. Any questions about this before I move on to the next steps? Okay. So going back to the actionable items that I discussed before from the qualitative work, the health services research work using the EMR is really looking at long-term outcomes of overactive bladder and what people can expect from their management. And I've been doing this work with one of our fellows, who's Dr. Zhang, who is soon to be graduating. And the thought was, what happens when people get to the end of the road? Let's say they have Botox or InterStim, what can they expect from their treatment? And so the way we did that is we took data from men and women with refractory overactive bladder, and we started by looking just at sacral neuromodulation, which is an advanced therapy for overactive bladder. And we tried to look at the outcomes of how many people need more after sacral neuromodulation, which is supposed to be sort of the third line in the end of the pathway, and how many people end up getting their device explanted. And this is the aims for that. So this is just our institution. So we found about 320 people with InterStim devices or sacral neuromodulation devices with OAB over the past 10 years. And of those, about 250, which is about 80%, which is very consistent with the literature, underwent a full implant. So for these implants, there's a trial phase, and it's about 80% of people undergo a full implant, which means it was successful, at least initially, for their symptoms. And what we found is about 40% of those 250 needed additional treatments for overactive bladder after getting their device. And the explant rates were it depends between groups, but between 10 and 25% of people had their device explanted. And so we did a Cox regression to see, what's the median time to getting another therapy, and it's about 4 years. And overall, the most likely thing that people will do is that they will start a medication about at that 4-year point. There is a subset, about 10% of people, that will go on to have Botox in addition to their InterStim, so a second, third line therapy. We looked at if there were gender differences, and there really wasn't any huge gender difference in the time to additional therapy. And then we did a regression model to see, are there any factors that that might contribute to people failing these third line therapies or needing more, that we could maybe counsel those people on, hey, you're at a higher risk for needing something more down the road. And all we could find is that people who are diabetic or had a higher BMI were more likely to have an increased hazard of requiring additional therapy after their sacral neuromodulation. And so this has really changed how I counsel people. Again, going back to that thought of OAB is chronic and it's not really a linear roadmap. And so now I do tell people that there's about a 40% of people at 4 years are going to need something else after their neuromodulation device is placed. And people who have higher BMIs or have diabetes are more likely to be in that 40%. And I think that has made it better, made at least me feel better, that people have some insight of what they can expect down the road. Okay, so as far as next steps, like where are we going with this? For that project with the sacral neuromodulation, we're expanding that to include Botox, and to see, how many people stop doing Botox and at what time and what factors are associated with it. And then the goal is to use those regression models to hopefully make maybe a prediction model, so that we could have like a calculator to say, this is your odds of needing something else down the road. My next steps in this are to submit this R01. And the R01 is definitely informed by by all of this work that I've done. And it's really focused on what I think is the biggest barrier, which is step therapy. And I feel from this work, especially the interviews, that step therapy might prolong the time that it takes for people to get therapies that are most beneficial for them, and also might cause some people to just leave the pathway altogether due to frustration with the model that we currently have. And so my R01 will aim at trying to identify who are those people that actually get to those third line therapies, which are now being referred to as minimally invasive therapies for OAB. So Botox and InterStim and PTNS, or sacral neuromodulation, sorry. And then to quantify the impact of insurance status on the utilization of those therapies, with the hypothesis that so those therapies are pretty universally covered by Medicare, and there's not a prior authorization process, whereas most private payers require prior authorization. So the thought is that, or the hypothesis is that time to getting these therapies is going to be less in people once they turn 65 than in people when they're younger than 65, and solely because of Medicare policies that differ from commercial insurance. And then finally, I'm hoping to use conjoint analysis to see whether clinicians and patients, like how much they would value having a system that doesn't require step therapy. So what conjoint analysis will do is try and pitch different scenarios to people and see which one they choose, and from that give me a set of coefficients or utilities of how beneficial would this be, and that's sort of addressing some feedback I've gotten that maybe people don't want to do an invasive thing if there's a medication, and most people are going to want to try and go through this step, which I don't think really aligns with what I found in interviews. And so that's trying to address that in a way that's not an RCT, like a head-to-head comparison of the different pathways. So that's all I have. This is my really great team here. I'm really pleased and grateful for the CAIRIBU support, and definitely the K12 funding that has given me the gift of time to do all of this work, and really feel like I can understand my patients and other people's experiences treating this condition.